Thank you for, it's my great pleasure to be here today. If I can figure out how to advance the slides. So in my talk, I would like to start off by setting the stage by discussing the broader context of population aging and factors that make older adults' health literacy and their decision-making environment such a pressing and timely challenge. And then in the third part of my talk, focus on the role that family members often play in bridging health literacy deficits of older persons, and talk a little bit about emerging interventional research related to challenges and opportunities to effectively involve family members in older adults' care delivery. So I want to just start off by acknowledging that we are living in unprecedented times with respect to expectation of life. This figure graphically depicts radical global demographic change now underway, reflecting the two lines reflect the proportion of the population ages 65 and older in green and less than 5 years of age in blue. You can see that the two lines intersect in the here and now, and that for the first time in human history, there are more individuals 65 years and over than children under the age of 5, and that this trend is projected to continue into the foreseeable future. The extension of life is a fantastic accomplishment that has enabled previously unimaginable feats, such as the first centenarian to finish a marathon, and the Iron Nun, who at the age of 82 swam 2.2 miles, biked 112, and then went on to complete a 26-mile marathon and write a book, The Grace to Race. The main point is that older adults as a population are known for their heterogeneity. And I want to emphasize that many older adults have very high health literacy and continue to function at high levels in all facets of life, from academics to business to public service and politics. Despite the promise of more years in good health, the reality is that most individuals do accumulate age-related deficits, particularly as they enter their 8th, 9th, and 10th decade of life. For example, the numbers of Americans with Alzheimer's disease and related to dementias is expected to roughly triple over the coming 30 years, from about 5 million Americans today to 14 million by 2050, driven largely by the aging of the baby boomers into very old ages. So how we as a society plan to meet the needs of the growing numbers of older Americans with complex health needs and disabilities in the decades to come is an important issue that will only become more pressing in the coming years. Although heterogeneity is the defining feature of older age, as a population, older adults are at greater risk for being less equipped to successfully navigate health system demands. As a cohort, older adults tend to be less educated than working age adults. They also are less likely to have technology experience and the skills and access to a computer or a mobile device. They are simultaneously also at greater risk for age-related physiologic impairments that affect cognitive function, hearing function, and visual function that consequently leave them less able to participate actively in verbal dialogue, as well as to obtain and process information from print content. Older adults also experience, there are a number of other factors that also affect decision-making demand for older adults. Older adults are more likely to incur not just one chronic condition, but multiple chronic conditions that motivate more numerous and complex medical and behavioral treatments that can be costly and difficult to manage. Because older adults are at higher risk of low health literacy, they in many ways face double or even triple jeopardy, and that they're less able to obtain and process information to make appropriate health decisions while confronting a broader range of complex health decisions that bring them into frequent contact with the care delivery system, as we heard earlier in the panel today. They also face a complex health insurance environment that is more complex than the typical working age adult. So these factors collectively exacerbate the health literacy deficits and expose older adults to a complex set of medical decisions and other daily decisions. So this is an image from a 2006 paper entitled "Can Limiting Choice Increase Social Welfare?" in which the authors describe the health insurance choices that are confronting Medicare beneficiaries in the wake of the introduction of the Medicare Part D prescription drug benefit in 2006. And the authors lay out a premise that less is more, in suggesting that the Medicare environment often involves too many insurance options. So this is a difficult image to project, but it lays out the author's review of the set of decisions that are encountered by older adults with respect to decisions around low-income subsidies, supplemental employer, or purchasing a Medigap supplemental insurance plan, the decision to purchase a Medicare Advantage plan, as well as the Part D prescription drug benefit, which involves another set of decisions. So the paper articulates how income and eligibility intersect in a range of highly complex decisions that can hamper rational decision making. A number of other papers have also found that individuals who have lower educational attainment or cognitive impairment are less able to make effective decisions with regard to taking up an insurance plan that has greater generosity of benefits, for example. So the figure that I just presented relates to an important but relatively narrow set of decisions related to the enrollment into a health insurance plan. However, the adequacy of health literacy affects a much broader range of decisions. These decisions include routine daily activities such as when and how to access appropriate and timely medical care, issues around knowing and understanding treatments and adhering to them, relating to prescribed medications, as well as lifestyle, diet, and behavioral recommendations, the ability to manage bills and banking, as well as being able to detect and avoid financial predators, accessing publicly available benefits and community services, issues around hiring and firing direct care workers who may be engaged in helping older adults manage functional impairments and disabilities, as well as preparing for future long-term care needs and medical needs in the event of incapacity, such as the purchase of a private long-term care insurance plan or engaging in advanced care planning. So in the next part of my talk, I'd like to shift gears and talk about the role that families often play in bridging health literacy deficits. And I want to acknowledge the foundational work that has already been undertaken by the National Academies of Sciences, Engineering, and Medicine and its predecessor, the Institute of Medicine. The Retooling for an Aging America report draws attention to the role that family caregivers play as part of a care team and draws a striking and important disconnect in highlighting the fact that family caregivers typically fall into their role accidentally without any formal preparation or training, and they provide care that spans the range of, that really bridges the fragmented service delivery environment. And the report contrasts the family caregiver workforce with the health professional workforce, which is well-educated and credentialed to function in a more narrow scope of practice, and typically in care delivery settings that were specifically intended for care delivery. More recently, I had the privilege to serve as a member of the committee that produced the report Families Caring for an Aging America, which details the scope and the consequences of family caregiving for older adults as well as for family caregivers in society. The report summarizes what is known about family caregivers' interactions within systems of care delivery and makes a number of important recommendations that call for specific research, policy, and practice change to support a shift towards family-centered care. And some of these recommendations may be relevant to the roundtable deliberations. One of the major findings of the Families Caring for an Aging America report is that family-centered care is the reality in which many older adults manage their health. We know, for example, that 2/3 of older adults with disabilities manage their health in the community with the help of family caregivers. About 30% of older adults with disabilities rely on a combination of paid and unpaid help, and just 5% of older adults with disabilities receive paid help alone. In a series of papers involving a variety of methods, our group has found that about 4 in 10 older adults regularly attend medical visits with a family or other unpaid, what we call a companion, that these older adults tend to be sicker, they tend to have lower education, and they are more likely to have cognitive impairment. We know that their family members are not just present in a single visit, but they tend to be consistently involved over time, speaking to the role that family members play in coordination of care. And importantly, we find that the roles that family members play are highly varied and that can both benefit as well as detract from the quality of communication. For example, we know that when older adults with lower mental health function attend medical visits with a family member, that those visits tend to be shorter and there's less discussion of psychosocial issues. So these are data from a 2012 supplemental module of a nationally representative survey of older adults that I co-authored with my geriatrician colleague, Cynthia Boyd, where we asked about older adults' engagement in healthcare activities and how they prefer to involve both doctors as well as family members and friends in medical decisions. We found, looking at the left bar, that more than 2/3 of older adults reported managing their health independently. Looking at the middle bar, that about 1 in 5 co-managed their health with family or friends, and on the right, that about 1 in 10 older adults reported delegating the management of their health to family or others. For each of the 3 groups, we examined preferences for making medical decisions independently, collaboratively with friends, or to leaving decisions to families. And so looking at the left bar, we see that 3/4 of older adults who self-manage their health report making medical decisions independently, whereas less than half of older adults who report co-managing their health or delegating their health management activities to others make decisions independently. We see that in looking at the far right, that about 1/3 of the 4 million older adults who report delegating the management of their health to others report leaving it to family, sharing decisions, or making decisions independently. So collectively, these data speak to the heterogeneity of older adults and support the notion that respecting older adults' preferences means different things to different people. For some, it means respecting patients' autonomy. For others, it means either engaging families collaboratively or allowing families to really predominantly make decisions on behalf of the older adult. So one of the major conclusions of the Families Caring for an Aging America report was that there are numerous challenges to structural support of family caregivers in care delivery. For example, the traditional and entrenched systems that govern financing and delivery of services are not well aligned with support of family caregivers. Coverage decisions for reimbursable services don't compensate providers for additional time spent educating or counseling family members. The prevailing bioethical and legal regulatory frameworks that prioritize patient privacy and the protection of personal health information often impede information access for family members that may be appropriate and beneficial when they're involved in coordination of care or managing medications or prescribed treatments for older adults in the community. The clinical assessments that are used to formulate patients' treatments often ask about the availability to bridge deficits in physical or cognitive function to enact a care plan, but these assessments typically don't involve direct communication with families, and as a result, the the caregiver's ability or knowledge to manage care is of questionable veracity or simply not asked. And a challenge is that because there's no systematic assessment of whether a family member is involved or their ability to provide care, it's very difficult to understand how often families are involved or how their experiences affect care delivery outcomes. So I wanted to read a quote from a woman, a 60-year-old woman who recently talked to our study team about her experiences interacting with a primary care clinician who cares for her husband who has mild cognitive impairment. She says, if someone wants some alone time with him, if a doctor wants some alone time with my husband, that's fine, but the fact of the matter is he's not going to remember what was talked about. Clinicians get angry with me, and they're like, let him speak, as if this is a picnic for me, which it's not. And as a matter of fact, it's very disturbing to know he can't remember he had a stent put in his heart last month. So the main point is that the lack of a defined role of families in care delivery in both face-to-face and electronic interactions often leaves them in an adversarial position with providers in terms of advocating on behalf of the patient, in terms of having a voice in care delivery, or being able to access information that they need to be able to manage care effectively. So through a series of projects, our team has been iteratively developing and testing several versions of a patient-family agenda-setting checklist. This is a paper-pencil checklist that's meant to be completed in the waiting room in advance of a medical encounter. The strategy is predicated on the idea that these family, what we call companions, are motivated to support patients during medical visits, but they may not know about the patient's concerns for the encounter, as well as the patient's preferences for communication assistance. So the checklist has two different activities that are designed to help patients and families get on the same page by aligning their perspectives about the visit agenda and to clarify the role of the family in the visit. In a prior proof of concept study published in 2014 in the Journal of the American Geriatric Society, we presented findings from a study that excluded older adults with significant cognitive impairment, and we found that this approach was feasible, acceptable, and led to improvements in the patient-centeredness of care from coded audio tapes of medical visits. In a subsequent study we've just completed, we focused on older adults with cognitive impairment in primary care and also found promising results that are now under review. These are some quotes from that the study team collected through the course of the study. And the visits themselves, which were audio taped, highlights the complex and difficult decisions that occur during primary care visits of older adults with cognitive impairment that relate to safety, that relate to patient autonomy, as well as the ability to manage medications, challenges around driving and living arrangements. And I just wanted to show information about how the checklist was completed in this most recent study. And we found that overwhelmingly patients wanted the family member to play an active role in participating in visit communication. And we found that patients and families' concerns for their visit sometimes aligned, but sometimes didn't align, and that patients were more concerned about memory, and that families were more concerned about safety and problem behaviors, as well as planning for the future. So in my final few minutes, I wanted to just comment on electronic communication and strategies for engaging families in electronic communication through the consumer-oriented patient portal. As mentioned in the earlier panel this morning, electronic interactions are increasingly becoming a mainstream mode of communication, but it's known that older adults less often have the technology skills and access to be able to engage in electronic interactions, and that there is this presence of a digital divide. So there are a number of reasons that engaging families through the patient portal could be beneficial in terms of capturing and respecting patients' preferences for involving family, in terms of engaging family, what we call the family care partners, as well as capturing and stewarding high-quality data and issues related to patient safety. Many electronic health record vendors do offer the capacity to afford patients to enroll a family care partner and to provide that person their own identity credentials. However, there's been much less attention to this what we call shared access in efforts to date. So in partnership, in a series of papers in partnership with Geisinger Health System, we conducted a survey of the patients at Geisinger Health System who had registered for the patient portal and had shared access to a family member or friend. We found that uptake was very low. Less than 1% of registered adult patients at Geisinger Health System had shared access to their patient portal account with a family member or friend more than a decade after this functionality became available. We found that patients' motivations for sharing access varied widely by age, such that the older adults population, the most common reason for sharing access was with a family member or friend was that the patient themselves didn't use a computer, followed by reporting that the care partner helps them to manage their health. And importantly, we also fielded a survey to the care partners, and we found, not surprisingly, that care partners were far less likely to be suspected of low health literacy using the single item health literacy screening tool that was mentioned in the earlier session. They were had higher levels of educational attainment, and they were much more likely to access and use the internet on a regular basis, as well as the patient portal. So just to summarize, in my presentation, I highlighted the heterogeneity of older adults as sort of a defining feature of this population, highlighted data to suggest that many older adults desire or require family involvement when interacting with clinicians and the healthcare delivery system, and that health system processes to recognize and engage and support family caregivers are notably absent, but that engaging families may hold a promise as a strategy to both respect patients' preferences as well as improve quality of care and better support families. Thank you so much.